occupational health, and I believe she graduated 3 years ago. And before the second year of her MPH, she started working with the Forge study as a research assistant, and kind of dove right in. She was somewhat forced into the deep end in part too from the beginning, but has brought so much enthusiasm to this work, both for her love of biology, but just for her commitment to the women, who we recruit. And she started her third year while she was an RA. We had already kind of collected the qualitative data that Brenda, who's on the phone, helped to collect, as well as Dara Wright. And so I kind of said, oh, would you maybe want to look, analyze this data? And would you maybe want to sit in on this PhD level qualitative methods class with Dr. Boleg? And of course, Brianna, with her can-do attitude, said sure. And she really worked on this paper for 3 years. And it has not been an easy journey. It has really taken a lot of hard work and perseverance. So it's so great to see it in print, and it's already made an important contribution, and I know it will continue to be read and looked on as a model of how we can center Black women and other historically excluded groups in medicine in our science. And so with that, I'm going to pass it over to Brianna.
Hi, everyone. Thank you, Dr. Zota. Thanks, Jonathan. I'm super happy to be here, and thanks, everyone, for taking time out of your day. I know Mondays are crazy, so the fact that everyone hopped on today is really awesome. So let me share my screen here. I was telling Jonathan that I'm literally constantly switching between different platforms for work and stuff. So I'm like, okay, Zoom, let me get in the mindset of Zoom. So, okay, can everyone see this okay?
Yes.
Awesome, thank you. All right, so again, my name is Brianna. Dr. Zota mentioned, I completed my MPH at GW. I graduated in 2018. This project is something that is very near and dear to my heart. As Dr. Zota mentioned, it took several years for us to get it to the point that it is now out and published, but it was certainly a labor of love. And so I'm really happy to talk with you all about the qualitative work that we did, trying to understand more about Black women's experiences seeking fibroid treatment. And I'll also just share some of my lessons learned, both just working with diverse groups and also just utilizing qualitative methods to do some of this work. So please feel free to jump in with questions if you have any. I can't see you guys as I'm sharing this presentation, so you can just feel free to interrupt me if you have a question or need some clarification. So this
right quick, Brianna, yeah. you do want questions along the way?
Yeah, feel free to ask questions along the way. My presentation isn't too long, so I'll finish up with enough time for us to have a discussion at the end, but certainly if there are any questions along the way, feel free to jump in. I'd be happy to talk about them as we go. So just before I dive into talking about the research that we did, I first wanted to just kind of introduce myself to you all. I think that Dr. Zota gave a great introduction, and I know many of you individually, but I wanted to share just a little bit more about like my positionality. And this really comes out of the qualitative world, where I learned about the concept of reflexivity. And that is really sort of reflecting on and acknowledging your own background, your own experiences, and how that impacts how you see the world, how you interpret data, how you make connections. I think that social science researchers do a lot better job than those of us maybe in public health or in the hard sciences in realizing how our own personal beliefs and experiences really influence how we do research. And so I'm trying to do an even better job of really acknowledging that. So I wanted to start my talk with that. So this is actually a picture of me, my mom's to the left, then my grandmother, and then my aunt. And so I have been raised by incredibly amazing, strong Black women. I myself am a Black woman. I am a sister to a Black man. I'm a daughter of a single mother. And so all of these things really influence how I see the world, how I navigate the world, and influence the things that are important to me. In addition to some of those personal identities, I'm also a biology nerd, as Dr. Zoda mentioned. I'm a super huge sports enthusiast, which maybe some of you don't know about me. And I'll also be a first generation physician. I'm starting medical school in the fall. So these are all things that really impact how I do my work. And so I think that I hope that you all take away from this today is to taking some time to reflect on your own life experiences, who you are, what makes you you, what's important to you, and how that influences the work that you do. Another thing that I wanted to mention, particularly in a committee like this, is that I'm still learning. I would say in the last 6 years, especially, I've been learning more and more about myself, about folks who look like me, about the communities from which I come. And then at the same time, I've spent a lot of time unlearning very toxic or harmful stereotypes that I have been socialized to believe about myself or about people who look like me or about my communities through maybe just media or society or whatever. And so I think that particularly in diversity and inclusion work, we're not only learning by talking with others and listening to others, but we're also committing ourselves to unlearning maybe harmful things that we once believed. So today, I hope that I can help you all learn something new, maybe that you hadn't thought about before. I hope that you maybe hear something that makes you think differently. And then, of course, I hope that we can sort of think about some ideas for action as well. So with that being said, as a first year MPH student, I knew that I wanted to do research that was important for Black and Brown communities, partially because of my own upbringing and my own aims in life, but I really didn't know what that was going to look like. I moved to DC. I knew absolutely no one in DC, no one at GW, but that all quickly changed when I met Dr. Zoda. She was my academic advisor. And so after talking with her briefly about my academic coursework, then I quickly learned about her work in Forge, and I kind of fell into all that I'm going to talk about today. So I'm not going to go in depth about the Forge study, and most of you all are familiar with this study. So I just wanted to give a brief overview for those who maybe are not familiar. But Forge stands for Fibroids, Observational Research on Genes in the Environment. I'm a little rusty because I have been away from the study for about a year or so, but I would say the initial sort of aims of the study were to think about the contributions of endocrine disrupting chemical exposures on uterine fibroid outcomes. And so I'll explain more about fibroids in my next slide, but I just share this to say that I kind of jumped right in as a research assistant, doing interviews and medical chart review and sample collection. I was very excited about all these things, and I couldn't have imagined all that would have came from jumping into a study like this. So here's a little timeline. I started around here. So pretty exciting stuff and amazing to see how much things have been expanded. But for those who are unfamiliar, fibroids are non-cancerous tumors that develop in most reproductive aged women. So as you can see from this picture here on the left, they're literally like almost like globs of tissue. In person, they look like globs of tissue, and they can form either in the body of the uterus or sometimes on the outside of the uterus. And for those who experience symptoms, it can be pretty problematic. So women who have symptoms may have very severe bleeding, they may have severe pelvic pain. It can really impact a person's quality of life. Oftentimes, people may have to miss days at work or constantly be trying to go to doctors to try to get some treatment plans that can kind of put their symptoms at bay. So it's a really problematic condition for those who experience symptoms. And Black women are disproportionately burdened by fibroids. So Compared to non-Black women, Black women typically have an earlier age of onset, so fibroids start to grow a little bit earlier in Black women compared with non-Black women. Black women tend to have larger fibroids, so fibroids can vary in size. Like some might be only half a centimeter, some could be as large as a grapefruit, or bigger. Black women tend to have larger fibroids, more numerous fibroids, and Black women also can experience more severe symptoms. There are several treatment options for fibroids at this point. However, hysterectomy is still the only permanent treatment option for fibroids, which obviously can be problematic for those who are interested in having children in the future. Removing the uterus removes that option. And so this last statement here, although hysterectomy is the least preferred fibroid treatment by women, and Black women are generally more opposed to surgical management, Black women are still more likely to undergo surgery for fibroids compared with non-Black women. So most of you all are familiar with the connections that Dr. Zota has studied with environmental health, environmental chemical exposures, and fibroids. But if I was maybe talking to a less familiar group, people might be like, well, why? Okay, these disparities are important, but why exactly are you studying this in EOH? Like maybe you should be in maternal and child health or something. But Dr. Zota and I started thinking through a framework of understanding environmental health disparities within these broader sort of social and structural processes. So, the environmental health disparities that we talk about, whether that's unequal chemical exposures or occupational hazards, pollution in low-income neighborhoods, stress from racism or discrimination, things like that. All of these are situated within these broader upstream social and structural processes, really. And the way in which people are impacted by these issues really depends on the intersecting social identities that one has, the access to opportunity that one has, their level of privilege, the level of power that the community from which they come has. And so in thinking about fibroid treatment disparities, it's kind of all connected. So when we were sort of approaching this issue and starting to work on this study, we really kind of relied on a lot of the growing research coming out of intersectionality and a framework known as structural competency, understanding that healthcare experiences and perhaps, these treatment disparities with Black women getting hysterectomy at much higher rates than other women, it's not just about interpersonal interactions, right? It's not just about the conversation that one person has with one physician, but really it's shaping some of these broader social and economic structures that sustain health, sustain inequities and create inequities. So that's kind of the framework through which we were really thinking about this analysis and the framework through which we were thinking about the information that we got from interviews with patients. So to quickly just kind of introduce you to what we did, given those treatment disparities that I shared about in that first slide, we really aimed to understand more about the experiences of Black women seeking treatment for fibroids. We had a unique study population of women who were seeking surgery for the treatment of their fibroids at GW Hospital. So we had this great opportunity to not only recruit them for the sort of environmental exposures component of the study, but then to also ask them questions about their fibroids diagnosis experience, their interactions with clinicians, to ask them about, what their perceptions were about fibroids risk, what their family members and community members had to say about their condition. And so it really gave us a great opportunity to contextualize Black women's experiences beyond just naming the disparity, beyond just saying, well, Black women get hysterectomies at higher rates. Well, why is that? What are the circumstances surrounding that? So our research questions for this were, what are the factors that influence Black women's fibroid management decisions? How do issues of discrimination and/or microaggression by race, sex, and class manifest in their experiences seeking fibroid management? And how do Black women experiences vary by age, educational attainment, and insurance status? And that third one is really cool and important because since we focused specifically on Black women in our study, we were able to look at the varied experiences within our group of Black women. Far too many fibroid studies in particular had compared Black women's experiences or responses to white women or to non-Black women. And in that way, and oftentimes white women were serving as the reference group. So in that way, we really didn't get to understand more about Black women's experiences more holistically, but it really was just comparing their experiences to white women, which to me is not as valuable. And certainly we got pushback from reviewers about that stance, but I'm glad that we kind of stuck to our guns because I think that it adds a lot. So we conducted semi-structured individual interviews with the FORGE participants. For those who are unfamiliar, semi-structured interviews are basically where we had a list of questions, a list of open-ended questions that every research assistant asked of the participants, but they were open-ended, so they allowed for flexibility for participants to, add as much or as little as they wanted, but we still kind of had a structured way of asking and making sure that we asked every single question in every single interview. As I mentioned, we only included Black women in our sample. The majority of the Black women in our sample were predominantly single. Most were nulliparous, or meaning that they hadn't had children. The majority were privately insured. Our study population was very well educated. The majority of participants had at least a college degree. And a little over half of our participants were undergoing hysterectomy. About 45% of them were undergoing a myomectomy, which is when they just remove the fibroid, but they keep the uterus intact. So once you got all of that interview data, I performed a thematic analysis, which is a tool that we use in qualitative research to identify, analyze, and themes, and we included 37 Black women in our sample, which funny enough, when I was first learning how to do qualitative research and taking that psychology PhD level qualitative analysis course, and I told the class that I had 37 transcripts, they all looked at me in disbelief because that is quite a large number for both qualitative research studies, believe it or not. We had 4 major themes from our analysis, and I'm going to go into more depth of each of these themes and give you some examples of what some of our participants said. But in general, these are the 4 themes that came from the analysis that we did. And the first one was really focused on patient-provider interactions. As respondents talked about their fibroids diagnosis experience, their interactions with clinicians, and how that impacted how they navigated their fibroids care, what their experiences were in gynecologic settings. So that was a really valuable piece. Another closely related piece was this idea of the social and historical value of the uterus. So as you can imagine, folks might have differing opinions about how they, about a hysterectomy in general. So some women were okay with the idea of getting a hysterectomy or didn't feel positively or negatively either way. But then there were several patients who did not love that recommendation and even sort of conveyed mistrust of their clinicians or of the sort of the medical enterprise overall after hearing that recommendation. There were also participants who had concerns about how fibroids could impact their fertility, and then others were a little bit concerned about maybe how fibroids could be cancerous, even though, as I mentioned, in general, fibroids are non-cancerous. However, this was still a concern that was important when folks were seeking fibroid treatment and making their decisions. And then finally, one that I think is really interesting was the role of community. And so this theme really gets at the impact of folks' social networks and even just community norms about reproductive health, people's ideas about, Black women's health, and how those things were instrumental in how folks thought about fibroids, how they evaluated their medical options, and how they interacted with their clinicians. So I'm going to go a little bit deeper into each of these. And just so you guys know, I used pseudonyms for all of these. So these are not actually our participants' names, but these are their ages. And H refers to a hysterectomy. M, which you'll see on some slides, refers to myomectomy. So that's the treatment type that the person who is speaking had. I actually used names from women in my family for a lot of these. So just kind of pointing it back to that reflexivity, positionality piece. But so our first theme here on patient-provider interactions. So sort of breaking it up a little bit, we asked women about their diagnosis experiences. And so the diagnosis experience was really impactful in how participants initially navigated fibroids care and management. So that initial diagnosis kind of set the stage for their next steps. So in this quote here from Nina, it sounds like she had gone to several different doctors or several visits trying to figure out what exactly was going on. So presumably she was experiencing some symptoms of some time. However, she didn't necessarily feel like she was being heard. She felt like she was getting the runaround to the point where she just said, forget it, I'm just going to deal with the pain. So you can imagine for something like this, this patient is experiencing prolonged symptoms but not getting the answers or relief that she desires. So she's just in prolonged pain for no reason, perhaps based on not good interactions with her physicians. Ashanti talked about how the doctor explained that most women had fibroids and that hers were so small there was nothing to even be alarmed about. So in this case, she when she was first diagnosed, the doctor was like, oh, it'll kind of be okay. But Ashanti later talked about how now she was at the point of being told that she needed to get a hysterectomy. So it seems kind of like she was told before that she didn't really need to worry about them, but now she's at the place where she has to get a hysterectomy. So almost wishing that the doctor would have explained that this could be something in the future that you could need to be a little bit more concerned about. So just talking a little, about those kind of gaps in communication there. We also found something that was also interesting were that several women talked about their desire to get more information from their clinicians and desiring to have a larger range of treatment options. So exactly like for Pamela here, she talked about how hysterectomy really seemed like the only option for her. Like she didn't hear about any of the other medical procedures that could, stop the growth or lessen the growth or just remove part of the fibroid. She says that those solutions weren't offered to her. And so when we're thinking about fibroid treatment disparities, I've read a lot of times, Black women tend to have larger and more numerous fibroids, and so their cases are generally more severe, so hysterectomy is the better option. But this kind of experience strikes the question of, well, is that the only option being offered to patients as well? So again, this sort of analysis and hearing experiences from these patients allows us to put a little bit more context to things. This next theme, talking about the social and historical value of the uterus. So, we asked this patient, Lauren, about her interactions with clinicians, and this is a pretty lengthy quote, but essentially she had, talked with many other women in her life who had experienced fibroids and who were sort of navigating the same systems that she was to try to figure out her best treatment options. And she mentioned that all of the folks that she knew that were Black women, they were all recommended, to have a hysterectomy. And so she was like, I want to find another doctor because I don't want that. I want to keep my uterus. And so she goes on to say how her and the other Black women who she was in contact with, they all didn't know whether there was a concept that our uterus, so Black women's uterus, not being valued because we're Black women. And so she asked this, to me, very powerful statement at the end of, is it because we're not valuable as Black women? And so as you all can imagine, this is something that is rooted probably in more of like the broader sort of social and historical ideas about Black women in gynecologic settings. Unfortunately, Black women have had a host of bad experiences generally in gynecology and in medical practice and medical research, from forced sterilizations to medical experimentation, to maternal mortality, to just not being listened to in clinical settings, to our pain being undervalued, to be undertreated. And so this kind of idea, this kind of concern really points back to that broader issue. And so I remember when I first read this being kind of like, wow, this is something that as a clinician, I would want to be aware of, that, these patients are bringing in that frame of reference into every interaction with a clinician. So really important to think about. So we talked about fertility consequences and fear of malignancy. So as you can imagine, women who were under 40 years old were generally a little bit more concerned about fertility consequences versus those who were older, presumably because, women who were under 40 were still interested in childbearing. Folks kind of had different perspectives on whether or not surgery will be helpful or harmful. So Chloe, she was motivated to have surgery so that she could get pregnant, because she was concerned that fibroids could actually prohibit healthy pregnancies, whereas Lynette wasn't necessarily sure. She wasn't sure if she was making the right decision by having surgery. So these were all sort of questions that women had as they were making decisions about their treatment. And then there was a small minority of patients who were concerned that fibroids could be cancerous. And this is actually the motivating factor for them to go ahead with surgery, which is concerning since fibroids are not cancerous. So the fact that someone may be choosing surgery solely based on that fact maybe signals a gap in communication between the provider and the patient in terms of being fully informed about why surgery would be the best option for you. And then finally, this role of community piece. And so we found in our sample that most of the women in our sample were aware of fibroids as a health condition prior to their diagnosis, and they were most often informed by other Black women. So this really highlights the role of community. This really highlights sort of information sharing and education through your own communities. Like Lynette mentioned, most Black women in her life, in her age range, had experienced fibroids. And so this highlights communication that's happening outside of a clinical setting. And then, along those same lines, people's social networks and just norms within their own community about reproductive health were really instrumental in how Black women conceptualized their condition and how they evaluated their medical options and interacted with clinicians. So, for Jada, like her siblings were kind of really the driving force behind her finally deciding to do surgery. But then Cicely, she had a different sort of experience where it wasn't necessarily easy for her to talk within her community about her experience with fibroids because folks didn't really understand, or maybe it was a hush-hush thing. So just really kind of interesting stuff here, really kind of showing the nuances within this population and all of the things that women are considering and thinking about when it comes to fibroid treatment. So overall, we sort of were able to conclude that the Black women in our sample, their fibroid management decisions were influenced not only by their interactions with clinicians and social networks, but also by some of these broader social and historical conditions. So, whether it was community interactions, social network interactions, sort of that historical frame of reference when thinking about mistreatment in healthcare settings in general. And so these were all influential in how women made their decisions about treatments, how they navigated their decisions about treatments. And so, as I mentioned, this analysis really provided an opportunity for us to contextualize Black women's experiences beyond racial comparisons. So rather than just saying that, Black women are diagnosed at an earlier age, but delay treatment for several years compared to Black women, compared to white women, maybe we can start to think about, well, how often is it that Black women's symptoms are being dismissed for several years longer than white women? Maybe that is a reason for delayed treatment, So I think it provides an opportunity for us to start to think beyond just describing the disparity, to contextualizing experiences. And we really try to frame our conclusions around things that clinicians can do to better, change things within their own circle of influence and within their own clinical practice. And so, of course, we believe that clinicians should be trained to address their own biases and really offer a range of treatment options, because that was something that women, desired. And then, of course, provide intersectional structural competent care that centers Black women. So understanding that Black women bring a unique frame of reference to the clinical setting, and that there are so many other factors outside of that individual one-on-one interaction in a clinical room for 15 minutes that influence the way patients feel about treatment and feel about fibroids care in general. So we were, really excited to push this out, and hopefully, who knows what the future will hold for this, but it was really exciting to work on. So I know all of you guys are probably like, wow, well, I haven't done qualitative research, or maybe I'm not necessarily suited for this, or how does one even learn how to do this? And I will say that I was right there with you. When Dr. Zoda first approached me about doing this project, I was very much like, sure, I'll do it, because I pretty much say yes to a lot of things. But I can tell you that sitting in a PhD level qualitative analysis course, I was immediately overwhelmed when hearing words like phenomenology, social constructionism, grounded theory, critical realism. At the time, I was actually getting very involved and more in-depth in quantitative data analysis, across the way in the School of Public Health. I have been taking some advanced data analysis classes. I was excited to learn how to, run logistic regressions and everything like that. So it was a complete shift for me to really learn from the ground up how to do this type of work, how to be reflective, how to think about how people construct their own experiences. And so while maybe all of you or none of you will do qualitative work in the future, I think a lot of the lessons that we can learn from it is just to peel back the layers and to not take anything just from its surface value. Like Dr. Bolek, Lisa Bolek, who taught this course and was the co-author on our paper, she really pushed me to think deeper about any sort of disparity that we see, or any type of phenomenon that we see, and think about the why behind it, think about the layers behind it, right? So even in thinking about MPH coursework, we talked a lot about air pollution or climate change or fracking, and we would maybe touch on disparities, but then not so much really think deeper about who was most impacted by this, what people positioned in certain positions in society might suffer more, what structures in place, what social processes are in place that create this issue and then sustain it. And what from our end can we do about it? So I hope to encourage all of you, even if you never do a qualitative analysis, to at least take some of those tools of thinking deeply and pulling back the layers, and not just accepting the description of a disparity or the description of an inequity, but trying to understand the why around it a little bit more deeply. So to kind of transition here, I wanted to just talk a little bit about some of my lessons learned from working with diverse groups, by working with Black women, for recruiting patients who have generally been excluded from research, and particularly environmental health research. I wanted to give a little plug to Agents of Change and Environmental Health News, because I had an opportunity to write about my experience as a research coordinator in environmental health. And I thought it was fitting for this type of committee on how some actions that we can take to really include people from diverse backgrounds, communities of color, in environmental health research, and also on the flip side, in faculty, staff, and students as well, because despite the fact that a lot of the environmental health issues and just public health issues that we study in general disproportionately impact Black and Brown communities, we are still way underrepresented and often excluded from the work that needs to be done to address these issues in these communities. And so, for anyone who, I know that there are a lot of people here that are already doing this great work, but I kind of just wanted to summarize some of my lessons learned a little bit from working with diverse groups. And then hopefully, I know this is being recorded too, so if some EOH students watch it later too, that they can have some ideas as well. But one of the biggest things that I learned being a research associate for Forge was just learning how to address my own implicit and explicit biases and be committed to continued learning. So a big example of this was when we started recruiting transgender men for our study as controls in Forge. And this was my first experience recruiting transgender men in a study population before. And this population is one that is continuously and systematically excluded, particularly from gynecologic research. And so it was almost kind of a bit of a huge learning curve for me, just to be sure that I was addressing my own biases, if I had any biases, on how best to interact in the language that I use. I think especially in places like DC, where we are generally much more progressive, it's easy to think that you don't have any sort of implicit bias or even explicit bias groups that are different from your own. But again, it's about not only learning, but then unlearning any harmful or toxic stereotypes that you've had in the past. So that was a big part of my journey, was unlearning anything that I had learned, religiously growing up or something like that, and committing myself to continued learning, having conversations with our patients, being sure that the language that I used in both in communication and even in our consent forms was inclusive, things like that. So I would encourage anyone who is aiming to work with diverse populations who have been excluded in research, to really commit yourself to continued learning, even if you don't necessarily think that you have any sort of bias, to realize that there's always something to learn. And kind of to go along with that, to really be open and honest and collaborative with your study participants or with the communities in which you serve. For me, this really meant being super honest, being super open to feedback, being compassionate, even if I was super stressed, even if I had been up since 6:30 that morning, with the surgery, and really taking the time to care for the people and understand that we were in such a privileged position to get to hear women's experiences, to get to hear their stories. I was in such a privileged position to stand in an operating room as a physician took out their uterus, and I was the first person, I saw their uterus on the table before they did, so it was such a privileged position for me. So that kind of goes into my next one of really just honoring that, and you're not only honoring the study participants in general, but then honoring their knowledge as well. I think when you are working with diverse groups, it's important to realize that there's a lot of learning still left to be done. And so sometimes you don't always get it right. So Dr. Zoda and I were often having conversations about, ways that we can improve, ways that we can do things better based on insight that I received from study participants. The next thing is just really being patient when you're building trust. It's not necessarily going to happen overnight. People don't owe you to trust you. People don't owe you their vulnerability. And so I think it's really showing up, being honest, being patient, and being consistent that works. And the fifth thing is just not to rely on the status quo and be creative. And creativity also means being flexible, I think. So for me, that was like doing interviews on a Friday night or a Saturday morning because that was the best time to work for the patient, even though I wanted to sleep in or something. Trying new things, not being afraid to change things up. So those are, really the things that I kind of took away. And we were able to be successful, with the study. So this is kind of just in closing for me. I really think that as public health leaders, it's our responsibility to include the voices of all people, especially those who have been marginalized and who have been historically excluded. If not, we are really missing the mark. And so I hope that the study today that I shared with you really encourages you to think more deeply about the disparities that we talk about, that we see. If you're interested, even get involved with qualitative research, but really commit yourself to showcasing and highlighting and including the voices of all people and those who have been marginalized. I think that is one of our greatest tasks. So this is one of my favorite quotes by Cleo Wade. She is a Black poet. And I leave you with this mostly because I think that we can talk a lot about the issues with environmental health. We can talk a lot about what needs to be done, but at the end of the day, I think it's our responsibility to actually do it. So I'm out here trying to do the work every single day. I know so many of you that are on the call are doing that as well. So I just want to encourage you guys to do that in whatever that way looks like for you. So with that, I want to thank all of the women, both the women that I recruited, the women who were included in this, our data analysis from Forge 1 and 2, every single person who was willing to share their stories with us. We would not be able to do that work without them, literally. I'd like to thank Dr. Zoda. Everything that I talked about today is because of her. And so she gave me an opportunity and a platform to be able to do this type of work. So I am forever appreciative to that. Dr. Boleg, who was the social psychologist who taught me everything I know about qualitative research and was also a phenomenal co-author on this paper. Dr. Sherry Marfori and Dr. Gabby Moad, who were our physician collaborators. We recruited their patients. And they provided great insight as well. Of course, all the Forge research staff, past and present. I'm happy to see a lot of you guys here today, and thank you all so much. This is very much a team effort. Agents of Change, EHN, and of course, UW EOH department. So thank you guys. And if there are any questions, I'd be happy to answer them and just chat.
Thank you, Brianna. Stop sharing your screen so we can.
Yeah.
All right.
Got like 15 minutes left, so. Ooh, sorry.
That was so excellent.
Oh, thank you so much.
Yes, so many levels.
Any thoughts?
How about, because it's always hard to get started. I'm going to start a question because it always seems like there's a lag in the first question. So, I mean, one thing about this paper, not only was it challenging because it was both for me and you, the first time we're doing qualitative work, but also I think it was probably, of the 50 papers I've published, probably the hardest one to publish.
Yeah.
So it required so much work and perseverance on your part.
Yeah.
Can you talk about the publication journey?
Yes.
And some of the comments that we got and kind of that experience and what you learned and how you adapted?
Sure. So yes, like Dr. Zoda mentioned, it was a journey. I mean, I think we first submitted, man, was it? Honestly, I can't remember. I think maybe it was like toward the end of 2019 or early 2020. Right. I think, but anyway, I think we ended up submitting to 4 places. Like the 4th was the charm. But we originally submitted to the Green Journal, which is a pretty major gynecology, obstetrics and gynecology journal. And this was at the recommendation of one of the physicians that we collaborated with. And this was, and I think we were all kind of like, yeah, this would be a great place for it to be. We really were trying to target the clinician audience, since most of our recommendations were for changes at the clinician level and maybe within like hospital system level. And the feedback from that review was pretty disheartening, basically racist. Essentially, the reviewers, they had no issues with my actual analysis. Most did not even comment on the quality of the data analysis. They were primarily concerned with the fact that we did not have a white women reference group, and they were also concerned about the demographic of our population. So, like I mentioned, the majority of our study participants were highly educated, of pretty middle to high SES in terms of education and insurance status and things like that. And they were concerned that, you know, we never claimed to be representative of all Black women, but they were concerned that this was not really relatable to women that did not have, were not of that specific like SES status or whatever. And so again, they didn't really comment on the substance of the work. They just were, they rejected it essentially because we did not have a white reference group and because they did not feel that this data was relevant or informative for anyone else. So that was disheartening. One, because we already talked about what we felt was the value of focusing specifically on Black women. And two, you know, I think that would have been such a great journal for clinicians to really see and understand. So of course it was disappointing, but I really learned a lot about perseverance. That was my first time really experiencing that level of critique that I felt was quite unfounded. I was super fortunate to have Dr. Zoda and Dr. Bolek who were like, yeah, that's BS, like, let's just move on. But, you know, I think that it also just showed gaps in the field. And while people can scream Black Lives Matter and scream about inclusion and diversity, at the end of the day, we still have gatekeepers at the reviewer level who, you know, keep important work like this out. And we've seen that numerous times, even with these large, you know, New England Journal of Medicine, and there's been lots of controversy there as well. So, you know, we found a home for it. It's in women's health issues now. And, you know, I still think that, you know, the preprint got like so many reads. So I think that people are finding it and reading it. But certainly, I think for anyone that is doing work like this, you might get some racist feedback and you kind of just have to keep going, and you'll eventually find a good fit for it. So yeah. Anybody else?
Yeah, I have a question. Oh.
Okay, hi.
Then why don't you introduce yourself, Angela?
Hi, I'm Angela. I'm a current PA and PhD student. I just joined the Ford Research Study team, and I'm so excited to like. I mean, this presentation was great. I think it'll form my interactions with the patients. So yeah, that's me.
Awesome. Nice to meet you.
Nice to meet you as well. Great presentation. Congratulations with your publication. I was just curious. I think 3 of the 4 major themes have like clear clinician recommendations, you know, be transparent about options, kind of seek out how much communal support they have and so on. But how do you think clinicians should like explicitly kind of deal with the whole social and historical value of the uterus? Like that's a difficult conversation to bring up, and like you'd want to be like, yeah, how do you navigate that?
Yeah, I mean, I certainly don't have all the answers with that, but I think that it's important for physicians to understand. I think my biggest thing is them understanding that like the clinical interaction alone, that 15 minutes in a clinic room is not all that is informing patients' perspectives about their condition, about their treatment. And so I think one, like physicians need to be a little bit more aware of like the world around them a little bit, and just like history and how that informs how people navigate society. Like actually in one of my medical school interviews, they asked me like, if you could write a book on one thing like related to like medical history, what would it be? And I said I would write on the mistreatment of Black women in healthcare. And they were like, oh wow, that's really interesting. How'd you get involved with that, or how'd you get interested in that? So and I went on this whole rant, about why I think that that's super important and why physicians need to know about that. So I think it really starts even in the curriculum, making like, I think medical history should be a part of education, really understanding that like everyone doesn't enjoy going to the doctor. Everyone doesn't have positive feelings about their interactions with clinicians. And these are the reasons why. Or, medical mistrust, even if you haven't experienced, even if I haven't experienced it personally, those ideas can be passed down generationally. So like experiences that my grandmother had in Alabama, growing up in doctors' offices, those stories have been passed down to me and have been shared with me. So while that might not have been my personal experience, I know about hers, and you best believe that I walk with some level of caution when it comes to certain issues. So I think just really acknowledging that and recognizing that is maybe the first step.
Do you want to just say a word about structural competency?
Oh yeah. So structural competency. Yeah, I was trying to keep the slides a little short and sweet, but I could have talked all day about like structural competency. But I'm sure many of you have heard about cultural competency, which is kind of this idea of being, sort of familiar with people's cultures and how their culture and their background influences just, the way they see the world. There have been some critiques about cultural competency, really, because it's more than just culture. It's basically how society and structures value your culture or value you in a lot of ways. So structural competency really pushes beyond the idea of cultural competency and really thinks upstream about sort of broader macro level issues that can impact a person's health. So instead of just thinking about their background or the language that they speak or the country that they're from, but thinking about neighborhood level effects, thinking about policies. And so I think that it fits really well into environmental health more generally, and certainly intersectionality, because you can think about how people's personal identities intersect with social structures and social conditions, and how that can impact whether someone's going to have great access to care or terrible access to care, whether they're going to have a positive physician interaction or a negative physician interaction. So again, it's kind of looking upstream at the structural factors and processes that can put someone in, can give someone, positive healthcare outcomes or negative. So that's definitely something that we kind of tried to push in the paper as well. So yeah.
I have a question, Brianna, and great presentation.
Thank you.
Yeah, I don't know anything about qualitative data analysis, so this is great. So I'm wondering,
like 3 years ago.
So you mentioned, and thanks a lot for raising the point early on about positionality and where you stand. So how did the other research associate in their race? Because I read in the paper that they were Latina, and then another one, like a white research assistant. How did that, did you find that responses varied across?
So it's something that was like noticeable. I didn't do maybe like an in-depth kind of analysis of like how different the depth of responses were based on the interviewer. It's certainly something that probably could have been done. I mean, certainly there is data to support that folks feel more comfortable with, especially in healthcare settings, with providers of concordant race or ethnic backgrounds. And so it is possible that that could have been influenced in conversations. But interestingly enough, like I did read some some transcripts where like it was clearly a Black woman speaking to a white research assistant. And so the Black woman, as she was talking, acknowledged that the white research assistant might not necessarily understand what she was saying about this thing, or she was almost like she was explaining to the white RA, like, oh, in our culture, this is how this thing is, or this is how I would think about this thing. So while I didn't do sort of a formal like analysis to see like how maybe responses varied, I will say that there was some of that where like there was clearly sort of differences. But I think the semi-structured interview guide helped a little bit with that because all of the participants were asked the same questions. And even when there was concordant racial pairs, some patients were just really short and some were a little longer. I think in my environmental health news blog, I talked about how it's not 100% necessary that you have, Black recruiters recruiting Black patients, or, Asian women recruiters recruiting, Asian women patients. But it's really about sort of those other lessons learned, about those other sort of like being sure that you are addressing your own stuff, being open and honest, being collaborative, being real. Those are the types of things that can start to build trust, regardless of if you have the same shared background. The shared background helps, but it's not a guarantee. There are plenty of Black women that I recruited that we didn't necessarily click all the time, and that was okay. So, I think, but there's always learning there, I think. Well, thank you guys so much. I know we're close to time, so if anyone has any other questions, I'm happy to answer it, or you guys can reach out to me or whatever. But I really appreciated you guys all coming today, and this was great.
Thank you so much. It was so great.
I just wanted to add a comment.
Oh, wait, Tony has a question.
I know, just a comment. I wanted to say, Brianna, this is a great presentation, and like I had the opportunity to do the sub-study with gendered racism and its impacts on fibroids in Black women, and I'm presenting on the 12th, so I could probably send you the invite to that as well. But I thought this presentation was so great, and like you explained everything so great, so it kind of gave me perspective on my presentation as well. But I think this is such great work, and then I also resonated because I have a similar background where I was like more quantitative, and I'm in the epi department at GW, and then I got to do this qualitative research, which I found very impactful for like my personal life. So I just want to say
awesome. Thanks, Tony. Yeah, for sure. I hope to stay connected with all of you. And, I'm so, like I said, Dr. Zoda gave me an opportunity to be a small part of her empire, as it were. So I am super thankful to meet all of the rest of this lab and see how much it's grown. We were a one-woman team for a little while, so it's amazing. A two-woman team for a little while, so it's amazing to see all of you all here and contributing to that work. So thank you guys so much. And hi, Dr. LaPuma, great to see you. And
well, I just want to say it is so gratifying to see, this work come to this point, and, just to see how you present it and how you talk about the context and the big picture, and just so gratifying, right? What a journey. And
yes, a journey.
Yeah. I mean, then when you get to see presentations like this, you're like, it was worth it.
It was worth it. It was worth it. It was fun. Well, thank you all so much. And